Hi, this is Chris Bain at the University of Florida. This is a quick talk on ureteropelvic junction obstruction, what it is, how to identify it, and the surgical management. The intended audience here is for medical students at the University of Florida and visiting the University of Florida, although there's probably still some applicability and learning to be had for patients and their families. The first thing I want to highlight to you is that hydronephrosis in and of itself does not equal obstruction. And this was an actual slide presented by Dr. Stephen Koff at one of the annual urological meetings, and it just always struck me that it's this simple. Just because you see hydronephrosis doesn't automatically mean obstruction, so try not to equate the two. And that's really why when we talk about ureteropelvic junction obstructions, we try to identify, some people use the term loosely, to mean hydronephrosis. And just because you see hydronephrosis doesn't mean you have obstruction. So what we're going to go through is what a UPJ obstruction actually is, and then how you diagnose it. So we'll talk about the anatomy. We'll talk about different presentations of pediatric ureteropelvic junction obstructions, hydronephrosis, and ultrasonography, and how ultrasound can diagnose hydronephrosis and how it's graded. We'll talk about evaluating the function and drainage with diuresis renography, which is kind of currently the standard, although with time, we in the field have room to improve on this test. We'll talk about surgical correction, namely pyeloplasty, and then I'm going to give 4 illustrative cases to kind of try to tie all of this in. And I'm going to try to do this quickly in a quick presentation because I think the value in this is to cover it in a very superficial level and then talk about it one-on-one at a deeper level. So let's talk about the anatomy. This is the classic UPJ obstruction, and in general, you're more likely to see this in infants and younger patients. This is a kidney with the renal pelvis and this beige kind of tan color, and you see this very short stenotic segment between the renal pelvis and the ureter. And when we think of UPJ obstructions, classically, this is what we think about. This is a stenotic or intrinsically narrowed ureteropelvic junction obstruction. Again, typically see this in young infants and kids. In older patients or patients that have obstructions that develop over time, they may present with intermittent obstruction, and oftentimes this is due to a crossing vessel. Not always, but oftentimes due to a crossing vessel. This is an image from Campbell's, which is the main textbook in urology. I will say that this anatomical diagram is not 100% correct, but I think it gives the, basically presents the notion here that you have a vessel crossing over top of the ureter as the ureter collects urine from the renal pelvis, and that provides a kinking to the system and prevents the kidney from draining well. People can have duplex kidneys. Duplex kidneys being namely the terminology for kidney with a defined upper and lower pole. Out of this duplex kidney, you can have a complete or incomplete ureteral duplication. So in this diagram, it's an incomplete ureteral duplication where 2 ureters join to one, kind of a Y connection, and then join down to the bladder. But you can have 2 complete ureters all the way down to the bladder. In cases of duplex kidneys, when you talk about ureteropelvic junction obstruction or severe hydronephrosis in the setting of obstruction, you're almost exclusively talking about the lower pole. Upper pole UPJ obstructions have been reported, but by and large, the vast majority, almost as a rule, of obstruction occurs in the lower pole moiety. So let's talk about the different ways that these might present. They're various, and it's oftentimes related to embryology. So if it's an intrinsic obstruction, that is meaning a very narrow connection between the renal pelvis and the ureter, and the kidney is blown out from the very beginning, or I should say dilated, distended from the very beginning. Oftentimes you'll make these diagnoses earlier in the prenatal period. So a woman may have a fetal ultrasound for an anatomical scan, and hydronephrosis of a kidney may be detected that then later gets worked up in a postnatal period. Sometimes children and teenagers may have a urinary tract infection, and imaging of the urinary tract may diagnose severe hydronephrosis, and that may prompt a more thorough workup to diagnose an obstruction. I would say, generally speaking, UPJ obstructions are not thought to be the cause of urinary tract infections, although certainly we all have seen these cases. But in general, it's probably more an incidental thing where a urinary tract infection or what is thought to be a urinary tract infection is worked up, with imaging of the urinary tract, and that detects an obstruction. For some reason, maybe because of the narrowing being so high or the point of obstruction being so high or proximal, potentially kind of a privileged state, UPJ obstructions do not tend to present with infections. People can have intermittent pain, again, largely, or I should say oftentimes this is due to a crossing vessel. This intermittent pain would be the sign of intermittent obstruction, meaning there's periods where the kidneys drain okay, and then periods where the kidneys are very much obstructed. Again, oftentimes for a crossing vessel. This intermittent obstruction is commonly called a Diedel's crisis, and it's a point where the kidney is completely obstructed, and rest will allow the kidney to recover, the renal pelvis to decompress, and for the kidney to begin draining urine down to the bladder again. I should say that the diagnosis of a UPJ obstruction is controversial, and the indications for surgery are controversial, as well as nuanced, and so some of the things I say here may not be everyone's opinion, and so that's okay. I have the way that I was trained to think about it and have developed a way of thinking about it over time, and that may be subtly different from other people in other institutions, and that's part of the problem, is we don't have any real rigid classifications for ureteropelvic junction obstruction. Let's talk about the workup of hydronephrosis on an ultrasound and what this looks like. Some advantage of an ultrasound for diagnosing hydronephrosis is that it's a handheld system that can go mobily. It's quick, it's relatively inexpensive compared to other imaging modalities. There's no radiation involved, you can repeat it. One disadvantage is that you're only looking at anatomy, so you can't tell you can't gain any information about function or drainage of a system based on an ultrasound. Another disadvantage is that it's user dependent, and ultrasounds performed with one sonographer or one technician may not be equivalent to that performed at another center with a different sonographer, or the same center at a different day. So another thing that can change it is fluid status. So it is somewhat of a I guess I should say, a test that is not always clearly reproducible to achieve the same images and same results, and there can be some things that can change it, including fluid status and the technician, him or herself. This is an image from Campbell's on a typical kidney ultrasound. This is a healthy kidney. You see the upper pole on the left side of the screen, the back and side on the top, and then the lower pole here on the right side. This is a picture of a kidney in the sagittal plane or the longitudinal plane. You can pause and read the description there if you want to look at the arrow and the asterisk meanings. At University of Florida and in my training and currently here with my partner, we use the SFU grade, which is the Society for Fetal Urology grading system. This is one of two grading systems. This is the older of the two. There's a newer grading system called the Urinary Tract Dilatation Scale, UTD. There's a different scale for prenatal and postnatal imaging. Again, I don't typically use that, but there are some advantages, and some centers do use that largely exclusively. This is a normal kidney, and then this would be grade 1, 2, 3, and 4 hydronephrosis, basically corresponding to some renal pelvis dilatation, distension of the major calyces, distension of the minor calyces, and then distension of the entire collecting system, with the key finding being thinning of the renal parenchyma. Now, there's some nuance to SFU grading, and rightly it can be criticized. One of the main reasons it can be criticized is grade 3 is a widely, or I should say, is grade 3 hydronephrosis can be widely different. I'll put it that way. So there can be hydronephrosis like we see here with distension of the major calyces that technically meets grade 3 criteria, or you can go all the way down to the images that we see here where the renal pelvis is largely distended and the major calyces and minor calyces are largely distended. But technically this is the same diagnosis as this first picture, because there's no thinning of the renal parenchyma. And I think I said major calyx up here, but I would say there's distension of the minor calyces. So all of these are grade 3, but they probably have different implications for the patient. There's other imaging modalities I want you to be aware of. CT scans are useful, particularly if intravenous contrast is given, because you can look at vascular anatomy. And if you wait some time, we're talking 5, 7, 15 minutes, that contrast will be picked up by the parenchyma, dumped into the collecting system, and you can see the collecting system anatomy as well. And that would be called a delayed nephrogram phase or a delayed urogram phase. Excuse me, a delayed nephrogram would be as if the contrast does not make it to the collecting system. A delayed urogram phase would be if once the contrast makes it to the collecting system, you can illustrate the collecting system more clearly. People are using increasingly MRI to diagnose or to work up urinary dilatation in the pursuit of a UPJ obstruction diagnosis. It's useful to identify crossing vessels and aberrant anatomy, and that's what I use it for in my practice. I should say that there's a difference in an anatomical MRU, which is what I have at my center, and a quantitative MRU that some other centers have. A quantitative MRU is a study that actually looks at, using statistical models, the rate of the gadolinium, which is the contrast for an MRI, traveling through the renal parenchyma, through the collecting system, and then down, transiting down towards the bladder. And using very sophisticated mathematical techniques, they can try to identify function of the kidney and then drainage or obstruction of the kidney. A strictly anatomical MRU doesn't do that. It just allows it doesn't have the software necessary and the really strict protocols necessary to determine function and drainage. You just let the gadolinium drain from the renal parenchyma to the collecting system, and then you make assessments of the anatomy on that. To evaluate function and drainage, this is really the hallmark of diagnosing UPJ obstruction. So you want to be able to identify that a kidney is functioning at all. It has to be able to function to see obstruction. You also want to be able to make sure that you see an obstruction to drainage. And so if you were designing a test to evaluate function and drainage, you would pick a test that was non-invasive, that's quick, radiation-free, objective, and reproducible. Unfortunately, the current standard for diagnosing urinary tract obstruction in urology and in medicine in 2022 is none of these things. This is a paper we wrote on diuresis renography, which is the test I'm going to describe for you over the next couple of minutes. I'll put the link to it in the description. I think this will get into the nuances of the test in a deeper way, and it's important to know that diuresis renography is a fickle test, and if you don't do it in a very rigid way, in a very protocoled way, it's hard to understand your results in the context of a patient, and it's hard to do that on patient after patient after patient. So it's hard to be able to apply the same standards or indications for, say, surgery, unless you have a really rigid and standardized diuresis renography protocol. So nuclear renography or diuresis renography, these are the key points that I've listed here. This is a test that involves giving a radiotracer by an IV line. The two most common that are used are DTPA and MAG3. MAG3 is preferred, I think, because I prefer it, and I think it's preferred in the field because it's not only filtered, but it's secreted into the collecting system, so it's a little bit faster than DTPA. Both of these radiotracers bind to the proximal tubules, and that allows you to define your differential renal function. You then watch the tracer drain from the chordal parenchyma to the collecting system, and you assess drainage as the tracer drains from the collecting system down to the bladder. By convention, you assess this drainage both before and after you give furosemide, which is a diuretic that tries to challenge the system. And as I said before, this is a fickle test, but one thing that can be very helpful is to ask the patient if they can communicate with you, and if they're old enough to, if they had pain during the test. Because oftentimes what you'll find in patients with intermittent obstruction is that giving the diuretic and flushing or challenging the kidney actually reproduces the pain that they feel intermittently. And that would be diagnostic of ureteropelvic junction obstruction. So this is an example of a series of analog images from a diuresis renogram. In this particular diagram, all these images are 1-minute images after the radiotracer has been given. So what we see here is the right kidney picks up the radiotracer very quickly in minute 1, and then by minute 30, you can see the tracer has drained to the collecting system and then largely out of the kidney. Contrast that with the left, where the tracer remains within the parenchyma of the left kidney. This is diagnostic of acute cortical retention or acute obstruction, which would be pathognomonic of a UPJ obstruction in the setting of a severely hydronephrotic kidney, where the ureter itself appears normal on ultrasound or whatever other imaging you may have. This is another example of nuclear renography imaging, and what I want to highlight here is that you can see in these pictures a region in colored lines being drawn around the different kidneys. And it's really important that these regions are drawn correctly by the radiologist or the radiation technologist, because the entire crux of your renogram is based on the computer or the camera detecting the radiotracer activity within these regions of interest. And this gets very nuanced, but I just wanted to highlight that at the beginning of that first 30 minutes, after giving the radiotracer, or in this case, this is probably after giving the diuretic, so 30 minutes into the study, the shape of the kidney will change. So it's important that the radiologist or the technician not draw the image in the beginning, but wait till the end and then go back into the test backwards and calculate the drainage curves based on that. I've said already that patients can present with intermittent obstruction, and this is what we see here. This is a series of images from a 7-year-old boy who presented at a period, who has had recurrent flank pain, and a diuresis renography study is done at the time that a patient does not have pain. This is their ultrasound, and then this is their differential renal function, a normal appearing differential renal function, 50-50 split, and then this is the tracer drainage, which is very good during the study. Now, this is when they present with pain. You can see the collecting system much more dilated, much more distended. And then here the radiotracer is draining much more slowly from the kidney. So that's why the timing of this test is also important and can be really influential in whether or not you may pursue surgery or how you deal with the patient in this particular scenario. So let's talk about the surgical correction. UPJ repair in children has a variety of options. You can perform temporizing measures like stent or nephrostomies. The mainstay, and that's what I'm going to talk about next, is pyeloplasty, but there's other treatment options here: Ureterocalicostomies, vascular hit stitches, and endoscopic treatment, which have been described and used, all of them successful in various scenarios, but by far the mainstay is a pyeloplasty. So these are all the different ways that one could perform a pyeloplasty. You could perform it with an open incision, you could perform it laparoscopically or robotically. Through an open incision, you could make what's called a dorsal lumbotomy incision, which is an incision here shown in the photograph through the back. It does not go through the thickest back muscle, but it goes just off to the side in this dashed line of the back muscle. And you're basically dissecting directly through the back to the kidney and repairing the kidney that way, versus going anteriorly through the abdomen or through the flank. You're going straight through the back. There's other approaches of course, you could do a midline incision, but the most common other approach in a child would be a sub or intercostal flank incision. This is a video that I made about the flank incision, and I'll post the link to it in the description. People have done this laparoscopically, and they've done it retroperitoneally. And so if you're going to do laparoscopic retroperitoneal pyeloplasty, this photograph is just imaging places where you might put your laparoscopic ports. Transperineally, this is an image from Campbell's. There's lots of different ways that you might put your laparoscopic ports, but basically you're putting them here in the anterior aspect of the abdomen. And of course, if you, in this case, this would be the blue dots would be the working ports, the green dot would be the camera port, and you'd be working on a left pyeloplasty. Robotically, the ports may be the same, and again, there's lots of controversy, well, I shouldn't say controversy, but debate on the best port configuration and these types of things. This might be a typical trocar placement for a robotic pyeloplasty. There is something that has been described by Patricia Gorgolo, who is currently at the Mayo Clinic, where the ports are placed through the umbilicus and then very low, and this produces what he calls a hidden endoscopic surgical incision. So in this scenario, if you were to put the ports like this, you could still operate on the right or left kidney. In this case, they're going to operate on the left kidney, and the port sites are largely hidden. A newer advance mint, and that's a controversial statement, is the single port robot. This involves, instead of multiple ports like we saw before, where the arms come from out and then converge to a center, the single port robot involves a single larger trocar starting in the middle and the arms converge out. And we can do a pyeloplasty in children like we see here through a very low 3 centimeter incision and work up into the flank to repair the ureteropelvic junction obstruction, but the incision is completely concealed. Here, this is a port site in the belly button, and then here, this is a port site, a single port robotic port site, very low in the pubic hair folds. Again, in this last picture, this is a left UPJ repair, but the single port is very low and we're working up, and there's only one incision that we use. Talking about pyeloplasty itself, this is the most common technique that most people will use. This is Anderson-Hynes dismembered pyeloplasty. Dismembered meaning you're taking the collecting system apart and then you're going to put it together again. Oftentimes in this case, the ureteropelvic junction obstruction itself is excised, although in some cases it's just spatulated and opened up and then put back together with the pelvis in a way that the neo-ureteropelvic junction is widely patent. You'll commonly talk about people talking about making the spatulation and the repair of the ureter at the posterior lateral border so that you don't interfere with the blood supply in this scenario coming from medially to laterally. This is another version of an Anderson-Hynes dismembered pyeloplasty, but in this case, what the cartoon is describing is tailoring or reducing the renal pelvis and making it smaller, so ideally to make the kidney drain a little bit better. This is somewhat controversial and is not practiced in all situations, but it is something that is important to know exists, particularly in kidneys that are so large and baggy that they may not drain well. There's something called a bypass procedure, which is a non-dismembered pyeloplasty that has been described here. There's something called a Foley Y-V plasty, which is also non-dismembered. Again, you're just making an incision and putting the renal pelvis and the ureter together in a way that provides a widely open neo-ureteropelvic junction. If you have longer stenotic segments and big distended renal pelvi, you can make what's called a flap correction or flap repair, which is to cut a flap of renal pelvis and then bring that down to augment the ureteropelvic junction. If you have a particularly long segment here, you might have to wrap the flap around the back, and that's called a spiral flap pyeloplasty. Again, this is another form of non-dismembered pyeloplasty, meaning you're not separating the renal pelvis from the ureter itself. If you encountered a crossing vessel, you would have to do a dismembered pyeloplasty in order to transpose the ureteropelvic junction now anterior to the vessel, but the vessel posterior. This is a ureterocalicostomy. This is not oftentimes practiced at the primary time of repair, but this might be something that's encountered for redo pyeloplasties or bailout procedures where The UPJ is not actually reapproximated at the former site of the connection between the renal pelvis and the ureter, but the ureter is connected to the lower aspect of one of the minor calyces at the inferior pole of the kidney in order to facilitate draining. This is probably most technically straightforward in the case of a very large, baggy kidney where the renal parenchyma is extremely thin and it's a shorter distance to cut through the inferior aspect of the kidney to one of the minor calyces and then sew the ureter in that location. There's some other minor surgical points that I would point out, and that ideally it's easier to operate in a virgin abdomen, meaning an abdomen where there's been no surgery before and there's been no surgery on a renal pelvis or no stents placed. Repairs are often performed over a ureteral stent or a nephrostomy tube, or sometimes called a nephroureteral stent. In the photograph here, this is a picture of what's called a Pippe Sale stent, where the stent comes from the outside the body, curls in the renal pelvis, and then goes down the proximal portion of the ureter or of the repair. These tubes are often taken out at 1 to 6 weeks after surgery, depending on surgeon preference. One of the requirements is that you have to perform follow-up imaging to make sure that your repair worked. And it's controversial how you might follow these patients up, but obviously the most common is that people would use ultrasounds or repeat the renal scan because if the pretest showed obstruction. Oftentimes it's very useful to show drainage on a renal scan, although that's a controversial statement and certainly people will take some issue with that. So on to 4 quick cases. The first case I wanted to show you is that of a 4-month-old girl with prenatally detected right hydronephrosis. She's an otherwise healthy girl, and an ultrasound at 2 months showed grade 4 hydronephrosis, and that's shown here in the sonogram. The MAG3 diuresis renography, this is the pre-diuretic phase. You can see on the right-hand side that the right kidney is picking up the tracer and looks very stagnant, whereas you see drainage on the left-hand side. You see very little to no drainage on the right. And I should comment that these images are actually, I'm going to go back for a second, these images are 3 minutes of compressed images, so they're not like the other images you saw before, which were 1-minute frames. These are actually 3-minute frames compressed into one image. This is the post-diuretic phase, so they give furosemide, and there's really no drainage whatsoever. You can see the drainage curve over 30 minutes actually rising as the kidney continues to accumulate radiotracer. That's the solid line. Meanwhile, the dashed line is a completely emptied kidney. So in this 4-month-old girl, a right retrograde ureteropallogram showed a short stenotic UPJ, and you can see that image right here, right by the renal pelvis and the ureter. There's a very short stenotic segment. We performed a right dismembered pyeloplasty via a subcostal 12th rib incision, and the ureteral stent was removed 4 weeks later. Now the ultrasound shows decompression of the collecting system on the right-hand side. This is a repeat MAG3 scan showing some drainage pre-diuresis, and then after diuresis, the right kidney empties nearly completely, and you can see the curve looks much different as it just abruptly indicates drainage very quickly. Case 2 is a 9-year-old girl. She was born with a minimally functioning right kidney. She began having acute onset left flank pain with increased fluid and soft drink intake, and really the left kidney in this case was the better performing kidney. The right kidney contributed really minimal function. Retrograde ureteropallogram showed a very long 5-centimeter stenotic proximal ureter with an anterior and high inserting UPJ. And so if you look at this picture, it's easy to think that maybe the ureter inserts at the bottom of the renal pelvis here, but it actually is inserting kind of in the middle. So the ureter is wrapping up over top of the renal pelvis and then inserting, which is what you see here. She underwent a left robotic flap pyeloplasty, and I guess I don't have the follow-up images here, but she did quite well. Case 3 is a 17-year-old girl. Actually, I'm going to go back for 1 second. The reason she underwent a flat pyeloplasty, just to illustrate this, is because the stenotic segment was so long that it was impossible to bring the healthy ureter up to the renal pelvis. So we had to create a flap of tissue that would flap down and meet the healthy ureter. So that's why she underwent a flap pyeloplasty. Case 3 is a 17-year-old girl, several years of right-sided flank pain that was withstanding. We did an MRU that showed severe right hydronephrosis and a tortuous UPJ with a crossing vessel. What I'm about to show you, or this particular image, is a T1 image of the MRU with a 60-minute delay on the gadolinium. So this is 60 minutes after giving the gadolinium. We kind of see this. And if you look anterior to the renal pelvis, you see it begin to kind of hook. And that's where there's a vessel running and kind of hooking the UPJ. We did a MAG3 diuresis renogram, and you can see the left kidney picking up the radioisotope and then beginning to drain. The right side, on the other hand, was just still collecting the isotope. The differential renal function here was 48%. Post-diuresis, left kidney completely drained, tracer completely stagnant in the right kidney. And you can see the drainage curve basically flat. She underwent a right retrograde ureteropelvic here, and you can see a serpentine-like stenotic UPJ segment that was suggestive of a crossing vessel. Right where you see the ureter come out of the renal pelvis and kind of dip and then come back up, almost like an S. That's right where the crossing vessel was running right over across that, kind of kinking the ureter. She underwent a right robotic dismembered pyeloplasty. She had a ureteral stent for 4 weeks. And she's doing quite well after surgery. I made a video of this case just to illustrate the concept of a crossing vessel. I'll put the link in the description. This is her post-op ultrasound a year and a half later, a completely decompressed kidney. So case 4 is a 16-year-old boy. He had severe left flank pain that occurred most prominently after sports practice. When he was drinking lots of water. An ultrasound showed a duplex kidney. Here you can see a left kidney with a healthy left upper pole and then a very distended lower pole. Retrograde ureteropelvic showed an incomplete ureteral duplication with an acutely angled lower pole UPJ, and you can see that right here at my arrow. So this is the incomplete duplication where the two ureters join. The upper pole was fine. And then right here, where the contrast is more dense, shows that the ureter is layered on itself. He underwent a left robot lower pole dismembered pyeloplasty and has done quite well from that. So in conclusion, I want you to remember that hydronephrosis does not equal obstruction. UPJ obstructions present differently by age and anatomy. The diagnosis is nuanced. Some are more straightforward, and some require some work to kind of cinch the diagnosis. And so I think you have to be patient with it and not just assume that all grade 3 to grade 4 hydronephrosis is always equal to a UPJ obstruction. There are many different types of repairs with excellent success rates, and the repair that might be done oftentimes isn't determined until the time of surgery when someone does a retrograde ureteropelvic, or you get in and you see the anatomy. In some cases, you might have an MRU that gives you a good idea, or a CT scan or some type of axial imaging that gives you a good idea of the anatomy. But oftentimes in a young child, you only have an ultrasound and a MAG3 scan, and so you don't actually have a completely clear idea of the anatomy until you get there. And you just need to have all these repairs in your armamentarium so you can adjust and respond appropriately. And I think one of the modern challenges that not just me, but a lot of pediatric urologists, particularly those that do robotics, are trying to, I guess, push is the concept of a completely hidden incision. And I think that this is something that, as a field, we're getting closer to. I think we're almost there. There's still a lot of debate on whether or not the right way to do this is with a multi-port or a single port. In reality, if you're hiding incisions and giving kids good surgical outcomes, probably doesn't matter what robot you're doing. It's just whatever the surgeon's preference is. But we are getting to the point where we can do this with a completely hidden incision, which is pretty neat compared to what people had to work with 30 and 40 years ago. So this is it. Hope you've learned something. I'd love to discuss anything else any other questions you may have. Thanks.